The next talk will be more on how this imaging is helping in the real time to the in the procedure by Dr. Reddy. Dr. Reddy is board certified pediatric and adult CHG specialist. He is the director of cardiac cath and interventional laboratory at UT Southwest at Dallas. So he is the medical director of multidisciplinary Fontan single ventricle program at Children's Medical Center Dallas. And he started the MRI guided cath program at Children's Medical Center in 2017 with Dr. Tariq Hussain. And their ICMR team has performed more than 100 MRIs, MRI guided cath procedures. And this is something is a forefront of technology, and hardly a few institutions in the country perform these procedures. So welcome, Dr. Reddy.
Thank you, Arpat. Greetings to everyone. Good morning to people in the western part of the world, and good evening to the rest on the other side of the world. We heard two amazing talks. Before I move forward, I want to thank the foundation and all the organizing committee, including Arpat and my co-panelists, to bring us all together to talk about advances in medical imaging. Now, if you see the next phrase, it says diagnostic to therapeutics. What Dr. Adebu and Ashu, Dr. Tandon talked about is how you can utilize advanced imaging and virtual and futuristic imaging to help surgeons and interventionalists so that we can all take good care of the patients. We all come together to do one thing, take good care of our patients. I'm going to take a different take on this, which is talk about ICMR, which is goes by multiple names: MRI guided cardiac catheterizations, MRI fluoroscopy, et cetera, et cetera. I call it ICMR to keep it brief and short, Interventional Cardiac MRI. Like Dr. Adebu, I have no major financial disclosures, but there is some research funding for me here from the Mass Foundation and CCRAC research grants. And this will be the outline of my talk today for the next 15, 20 minutes or so. As I suspect, some of us in the audience may not have been exposed to ICMR. So I'll go over the details of that briefly and then delve into our Dallas infrastructure and our cases that we have done here at Children's and UT Southwestern in Dallas. On this slide, you'll see the two standard images, which is the gold standard cardiac cath procedures, where you can see the bones and the wires and the skeleton. And then you imagine me, the plumber, the interventional cardiologist, imagines a three-dimensional structure, and we get the gold standard hemodynamics, saturations, and pressures. While the rest of my panelist team are used to seeing these beautiful images of CTs and MRIs. On this specific slide, it's MRI that shows us images of the heart, lungs, liver, and all the adjacent structures that you can actually see. You do not have to imagine anything. And the gold standard here being you get best data for volumes, function, and many of the things that the cath data set would be left desirable. How about if we combine both of these together? We bring these two together for the same patient under one anesthesia, then you get the best of the both worlds. And that's why it's called a one-stop shop. ICMR, interventional MRI, is on your left-hand side. You see the tip of the balloon, which is filled with 1% dilute gadolinium, being advanced in a patient with the Fontan pathway. You can see the balloon down in the LPA, and you can see it. I don't have to imagine, me as an interventionalist, I do not have to imagine the left lower pulmonary artery. I can see that pulmonary artery there. I can see the aorta there, and I can see the balloon going across or in between the neo-aorta and where the LPA is being obstructed as the balloon is pulling back across into the Fontan pathway. So that's the beauty of doing these procedures together. And it's not just the beauty and the ease of it, but you get incremental data. MRI on the right-hand side, you can see provides gold standard information on the volumes and flows and everything else. Catheter-based measurements with hemodynamics, pressures, and saturations. And you combine these two, and you get a lot more. And the best part is patients anesthetized once if it's a child, especially in a pediatric population. So we have one catheter and then one wire, which I'll go over in a few seconds. So before I go into the details of the wire, I want to brush upon the history of ICMR. This is not new. People have been doing this, or many institutions have been doing this for the past 2 to 3 decades now. And we at UT Southwestern, and I am standing on giants in the field, on the shoulders of the giants in the field who have done work. The Razavi's team at KCL London, Letterman's team at the NIH, they've done tremendous amount of work so far. And we have learned from their protocols and advance the field a bit further here at UT Southwestern and Children's in Dallas. So predominantly, right from 2002 to 2018 or 2021 now, most of the work has been in pulmonary hypertension patients, two ventricle patients, and Pushproj and their team have done a lot of congenital heart disease patients, single ventricle patients, but they've been limited because they had one catheter or a balloon wedge catheter. There's not much inventory to advance the field to do high-risk patients. And most of the interventions were actually performed in animals. You could see the proof of concept, but lack of equipment and inventory has prevented us to take this further to the human world. And that is something that we have done recently here. We have taken the only available wire for us in the United States, at least, the MR or the Emery Glide wire from Nano4 Imaging, which is also approved for or CE marked in Europe. We've used that wire to do a bunch of high-risk patients, single ventricle, congenital heart disease, cardiac catheterizations in the magnet. Thereby, we reduce the radiation and also get a lot of additional information with one anesthesia. So what is this wire? This wire is an MR-compatible wire with 3 markers at the distal end. And you can see that it gives you a susceptibility artifact. And I call it a caterpillar. It has these 3 markers, and that's the wire. The rest of the wire is not seen. And the balloon tip catheter, we inject 1% dilute gadolinium in the tip of the balloon so that you can see the balloon and the wire going across. For a right heart cath in this view, for a left heart cath in the middle video, we are showing the descending aorta being transferred with the wire and the balloon. And then on the right-hand side, you see the balloon and the wire being advanced across the aortic valve for a retrograde left heart cardiac catheterization in the magnet. With that, I want to delve into the details of what we do here in Dallas. We have, from an infrastructure standpoint, a biplane Philips cath lab, and through the double doors, you can see the magnet on the other side. And we intentionally separated this. A couple of other institutions that we've seen the ICMR work, they have a railroad, and a patient just gets transferred through a railroad. And our institution, we all specifically decided not to have that railroad for multiple other reasons. But the ICMR magnet is a Philips Ingenia 1.5 Tesla magnet, and we use specialized equipment to talk to each other so that we can hear our colleagues speaking back and forth through optoacoustics, which is a system that you probably should get if you're planning to do ICMR. What is our workflow? Well, we huddle before all cases. It is absolutely critical that all the major 3 teams that are the 3 teams which are critical, which is an MRI team led by Dr. Hussain, the cardiac anesthesia team led by Dr. Jen Hernandez, and rest of the team members here from the cath lab. We come together just before the case, discuss the patient's information, and then we get access in zone 3, and then proceed to zone 4 to do our baseline imaging, which I'll go into a further detail in a few slides from now, and then do a right and left heart cath. And once all the information is obtained in the magnet, we decide if additional testing is needed. For pulmonary hypertension patients, it might be nitric oxide hyperoxia testing. For patients who need pressure evaluations across stenotic areas and et cetera, we might have to advance wires across those areas and get pullback pressures. And then for patients with Fontan fenestrations, we can now, and we have developed that technique at our institution here at Dallas, we can do a Fontan fenestration test occlusion in the magnet, thereby getting incremental information, which is now these days routinely performed in the cath lab, but we can do better by doing this in the magnet. And if patients need any particular interventions, which we cannot do at this time in the magnet, then we can transfer them to the cath lab for that focused intervention for which they get radiation. Hopefully, that'll be a thing of the past if we all come together to advance this field. If patients do not need any interventions, then patients get extubated in zone 3 and then move on to recovery and potential discharge same day or next day. This is an overview of our cases so far. We've done more than 100 cases. And as you can see, our institution stands out because we do a lot of high-risk single ventricle patients in the magnet compared to others. And the way this field has evolved, ICMR or MR-guided cardiac catheterization has predominantly been and continued to be used for diagnostic cardiac catheterizations to assess shunts and to assess pulmonary vascular resistance. I think there is value in it to continue to do that, but I think the best patient population who can benefit from doing these high-end combined ICMR evaluations would be our single ventricles, because if you just do a cardiac cath procedure, you would not get all the detailed information that you need from what you get from the MRI suite, and vice versa. If you just do the MRI, you would not get the hemodynamics and additional information and not be in a place to do the interventions that we do in the cath lab. So combining these two gets us the most beneficial effect for our patients. Amongst the single ventricle patients, my focus has been for pre-Fontan and post-Fontan evaluations. We can also do Fontan fenestration test occlusions. And back in 2020, last year, we did our first intervention in the magnet, which was a live case that was telecasted around the world to do a pulmonary balloon valvuloplasty using the wires. So how do I use ICMR Suite here at our institution? Well, we can think about it in two groups: single ventricle evaluation, two ventricles. For single ventricles, you think about all the three different stages: the stage 1, stage 2, stage 3. The best patients are for stage 1. If you're thinking about a shunted patient and you're debating, is this a potential two ventricle patient, ICMR will come into play. Stage 2, a failing Glenn or a blue Glenn who needs further evaluation should be considered for an ICMR. And stage 3, a failing Fontan or patient with a Fontan who has branch PA stenosis, collateral, and very atypical collaterals, or photosystemic shunts, or a pre-transplant evaluation for a failing Fontan should be good candidates for ICMR. Why do I think ICMR is a one-stop shop for single ventricles? Because you get, like we talked about already, hemodynamics with the cath-based measurements, anatomy and the volumes and function, etc., from the MRI. And these days, a lot of focus has been placed on the lymphatic imaging for these patients. And you get all of this with one anesthesia on the same day, with the same preloading and afterloading conditions, which is the best thing that you can do for your patient population, so that then you can make meaningful judgments with all the incremental data that you get together, not with the cath done 6 months ago or MRI done in 3 months from now. That data can be different because they're on 2 different days and the loading conditions are different. So if you get this information on the same day with the same internal homeostasis, if you will, then I think patients we, the team members, can work towards getting the best management protocols for them. So with that, we'll switch gears and look at some of our single ventricle case examples. The first one would be an ICMR pre-Fontan evaluation. What do we do for a pre-Fontan evaluation? We get patients in the zone 3 axis, goes to zone 4. Once we get to zone 4, we do our MR information, we do our right heart cath, left heart cath, and then this is a case example of one of such patients. This is a 4-year-old patient, 15 kilograms, hypoplastic left heart syndrome, status post Novotsano and a Glenn. He was referred for a pre-Fontan cardiac cath prior to Fontan palliation. First start, right heart cath, first pass, right heart cath took us about 4 minutes. Left heart cath took us about 2 minutes. What you see here is the tip of the balloon. You can see that because it's 1% dilute gadolinium, and not the rest of the catheter is not seen. And we used MR wire here to access from the right atrium across to the left atrium, and then obtain left atrium and pulmonary vein saturations, which was previously we couldn't do this in the magnet. Then we come out, and when we go back to the Glenn pathway, we are able to go down into the LPA with the use of the wire. And this particular patient had 30% collateral flow, which is a cutoff that we use here to transfer the patient to the cath lab for AP collateral coiling. That what you saw previously was the in practice sequence. Now we use what we call as the I Suite, which is a triplanar sequence. You have the AP view, if you will, and the lateral view that you can change. So the sagittal and the coronal views are changed so that the cath doctor like me can actually think while I'm in the magnet, can think cath world, AP and lateral views. And then you have the best of the both worlds, which is the transverse view, all the three views at the same time. And we can do selective angiograms. Move on to the next slide there. There you go. You can also do a detailed Glenn pathway. This is hybrid overlay I Suite evaluation, where you can see the tip of the balloon that is being advanced from the right pulmonary artery to the left pulmonary artery. And you can see this balloon really well with this hybrid overlay technique, which is again an advancement that we've been pushing at our center here. This is much better from a user standpoint, and I can see the balloon being deflated completely so that I do not get a partially wedged saturation, which was the case with some of our interactive sequence patients. So this is what we're doing currently, using triplanar I Suite sequence with hybrid overlay, so that you get all the information we obtain is quicker and faster, so that the patient's anesthesia total duration is not increased. This is something that I'm very proud of my team here. We're the first that we know of to show ICMR bubble study. This is for people who are not familiar with these stages. This is a Glenn patient who has bilateral branch PAs that has abnormal connections, pulmonary arteriovenous malformations, and you can see early return. And this is what we routinely see in the cath lab. But you can do the same by injecting 1% dilute gadolinium in the magnet with a very thick slab imaging, and you can show early return in the magnet. This has avoided some of my transfers that I used to previously transfer the ICMR patient to the cath lab to show this. But once we have developed this technique, we do not need to transfer these patients, and the total radiation dose is 0. Switching gears, we also do, thanks to the ICMR Suite, we also do lymphatic imaging here as part of the ICMR evaluation. Patients who, all single ventricle patients, we should do a detailed T2-weighted imaging and 3D SSFP. I saw Vasu Guti in the audience a few minutes ago. I don't know if he's still there, but he was our fellow from a couple of years ago. He published an article on using 3D SSFP and T2-weighted imaging. Both are non-invasive, and you can see the entire lymphatic, thoracic duct and the lymphatic systems. And then for patients who are high risk, we do the DCMRL, which is dynamic contrast MR lymphangiography. We place needles in the lymph nodes and mesenteric and hepatic lymphatic systems to assess the function of the flow of the lymphatic system so that we can intervene on them as needed. Moving on to the Fontan failure types. These are all the various ways that how a Fontan patient can fail. They can have systolic or diastolic failures, liver failures, or lymphatic abnormalities. And you can check for almost all of these using the ICMR systems. And this is our ICMR protocol that you see on the left-hand side. I'll not, for the sake of time, not go into the details of all of these, but you should see a review paper coming out soon, which goes over the details of all of these things. Just a quick example, you can see patients with Fontan-associated liver disease who are being referred for MRIs and cardiac caths multiple times over multiple years, but you can do this together. And you don't have to separate out those encounters. You can do the MR elastography at the same time, go across from the IVC into the hepatic veins and do a hepatic vein wedge so that you can get your portal vein gradients. And you can combine this information to make meaningful decisions as to what your patient may need moving forward. The last thing about Fontan, so the single ventricles is the ICMR Fontan fenestration test occlusion, which we were able to show here. This is on the left-hand side of the screen is a Fontan fenestration that you see with the jet that is coming across from Fontan to the common atrium. We place a wire in the magnet across the Fontan fenestration. Then we advance the balloon across the fenestration, or the wire comes out, balloon is inflated, and you do the test occlusion for 10 minutes. If the patient meets the criteria for Fontan fenestration closure, you go to the cath lab. And this time I cannot close the fenestrations in the magnet because we do not have the inventory yet, but one day hopefully we'll do that. But for the time being, most of the work is done in the magnet, and then for the next 10-15 minutes we get transferred to the cath lab for a device closure there. This is how we put together all of our data. We get the baseline cath information, baseline CMR information, Fontan fenestration test occlusion information, and post-test occlusion information, and we make meaningful decisions to decide whether these patients need to undergo fenestration closures or not. This is an example of the older way as to how we used to do Fontan fenestration test occlusions. You can see the wire with the interactive sequence getting across the Fontan fenestration, and then once we get across the fenestration, we'll advance the balloon across there. For the sake of time, I'll go to the next slide, which shows you the same, but with the triplanar sequence. So what you see here for orientation, the two red balloons that you see, one balloon is in the Fontan conduit, the other balloon is across the Fontan fenestration onto the common atrial side. And we are doing Fontan fenestration test occlusion for 10 minutes or so, and then assess for candidacy for closure. Switching gears, finally, two ventricle patients, ICMR is beneficial for if you have patients who have multiple shunts and you're unable to calculate accurate flows and PVR, so that you can tell the surgeon with a lot of confidence whether you need to go ahead and close those very high-risk patients with multiple shunts, close all of them in one setting, or stage them, or have a type of valve patch closures. I'll not belabor the point in the pulmonary hypertension. We know we can do that. Coarctations, especially patients with arch hyperplasia, and some TET patients might benefit from ICMR. This is an example of a patient with a coarctation, 5-year-old patient who had coarctation, and on echocardiogram, we would not know whether this patient had moderate or severe arch hyperplasia. So this patient was referred for an MRI, followed by a cath and potential surgery if needed. And we propose to do a combined ICMR procedure where we can assess the patient in the magnet, whether this patient has or does not have arch hyperplasia. We did our right and left heart cath in the magnet. MRI obviously gives you all the information that you need to know, and we noted a 49-millimeter gradient across the aortic arch, and MR imaging showed that there was no significant transverse arch hyperplasia. So we decided on the table, same anesthesia, to transfer this patient to the cath lab, and using the overlay techniques that both Dr. Adebo and Dr. Tandon showed, we were able to stent this patient at the magnet. So one setting, we answered the questions, did the intervention, and we got out. And these are the patients that will benefit the most from ICMR. And this is an example of our first-in-human balloon valvoplasty. This is the transverse axis, the lateral view for the cath world, where you see the balloon being inflated across the pulmonary valve. So to summarize, ICMR can be used for both single and two ventricle patients. Single ventricle patients benefit the most, but there are a big chunk of two ventricle patients who do benefit from ICMR, the combined modality. There are lots of pitfalls at this time, and there are many things that we need to do to take this ICMR to a futuristic at this point to become standard of care. The main things that I will talk about here is equipment. We do not have equipment. We just have a balloon wedge catheter and a couple of other balloons that we can potentially use in the magnet, and a short length wire. We need more. We need wires, balloon stents, so that we can actually do all the interventions in the magnet and take away radiation completely. And for that, we need to all work together with industry. To conclude, our newer ICMR techniques that we have developed here and across the world have enabled us to do a detailed right and left heart cardiac cath procedures in complex single ventricle patients, both pediatric and adult or grown up with congenital heart disease. And ICMR provides a more detailed and reproducible evaluation for our complex patients. So consider this as a one-stop shop, and this will not only help you with radiation sparing, but the incremental data that you get will help you to make better management decisions for your patients. I'll stop here. Thank you very much.
Thank you, Dr. Reddy, for the amazing talk. And I was not aware that we can do pediatric intervention. So that is something really new for me. Uh, so we are using the advances to decreasing the radiation, as well as providing comprehensive care and, for, as you said, one shop answer for all the problems.